Dr. Rupam.
Thank you, Chair. So our topic for discussion is whether we should look beyond HbA1c at today's era, and the answer we'll be finding out after our discussion with our experts. To start with, we all know that HbA1c we have been using since many decades now, but there are a lot of limitations of HbA1c with respect to finding out the glycemic variability. It's unreliable in certain conditions like anemia, hemoglobinopathies, liver disease, iron deficiency, and it affects the accuracy of HbA1c measurement. Lack of guidance for treatment adjustment is there. As we do HbA1c every 3 months, go deep into the insights, what's happening in real time. There is ethnic and racial differences as well. We know that African Americans and Hispanics have a higher HbA1c from 0.2 to 0.4%, and with every decade of our life, there is an increment of 0.1% of HbA1c. That means a person who is in their 20s, if their HbA1c is 7%, and somebody in his 70s, the HbA1c will differ by around 0.5 to 0.6% in those elderly people. This is the list of conditions where we can have unreliable HbA1c, including hemoglobinopathies, hemolytic anemias, recent blood transfusion, elderly people, and very interestingly, a person with high BMI also, we can see that the HbA1c is not reliable as far as their glycemic control is concerned. There are trials from ICSI. The guideline also states that level below 7% may actually increase the comorbidities or the outcomes with respect to death, weight gain, hypoglycemia, and other adverse effects. That's why they kind of recommend not being very stringent on our patients with respect to HbA1c, because it can be very decremental when a lot of hypoglycemias occur trying to get better HbA1c in our patients. So what needs to be done? We have modality like SMBGs or CGM that we use in our patient. In low resource settings, we can go ahead with SMBGs that can be continuous, 7-point SMBGs, or rotatory SMBGs that will give us the real-time insight, and CGM that we'll look in subsequent slides how it can be very helpful. And there are alternative glycemic markers like fructosamine, glycosylated albumin, and 1,5-anhydroglucitol assays, which can tell us more detailed glycemic control in our patient. So we all know about the CGMs. CGMs can also estimate HbA1c when 70% of CGM data is available, and it is called HbA1c, and that we can correlate with our glycemic variabilities, and we can compare with the laboratory HbA1c and come to our conclusion. So these all we do in our day-to-day practice, BGM and CGM. If you look into the most important point here is that is MARD, that is mean absolute relative difference. It stands 5% for self-monitoring and 10% for glucose monitoring. Let us give us one example. These two patients, they have similar HbA1c of 8%. But if you look into the glycemic variability of subject 1, he had around 7 hypoglycemic events and 8 hyperglycemic events as compared to the subject B who had none. This can be very real in our patients when we just compare the HbA1cs and we think the patients are in good control, but actually the patients are having hayward hyperglycemias or hypoglycemias. There are different recommendations for different subset of patients, but we have to remember is more than 70% of CGM time of throughout the day. We should have a good glycemic control. Less than 4% of hypoglycemias and less than 25% of hyperglycemias. That will give us really clinical benefits. There are many phases of this HbA1c 7%. If you look into these 3 datas, all the patients have HbA1c of 7, but then look at the glycemic variability. All patients have different kind of glycemic variability, which leads to complication in patients who has higher glycemic variabilities as compared to the third one who had a smoother variability graph. Lot of other factors also influence our subset of patients, like high carbohydrate diet. Personalized TI targets should be set for our patients. It should be individualized. There is ethnic differences. Specifically, I come from a place, Northeast India, where we find a lot of HbE disease patients where HbA1c is not reliable, so we have to do fructosamine assays. There are advantages of CGM, and there are also limitations with respect to cost, the replacement, and lack of clinical guidelines for CGMs. Very important point here is HbA1c, which is given by CGM data, and the laboratory measured HbA1c. We can compare both and get to a conclusion, but there can be some discrepancies between these two. That's why this is a new modality which is called Glucose Management Indicator, GMI, a modern tool for accurate glycemic assessment. We can go ahead with the calculation of GMI and compare it with the laboratory HbA1c. And important thing here to know is lower the GMI, then we have to be little relaxed on those patients not causing hypoglycemias. If the higher GMI than HbA1c, then we have to be very strict with respect to glycemic control. Glycemic variability is very important because it can lead to micro and macrovascular complication increment. So this is how a CGM data looks like. We have to also look into the coefficient of glycemic variability below 36%. My last 3 slides. These are the studies done in India to compare between HbA1c, OGTT, and SMB, and to look into which is more reliable with respect to diagnosis of type 2 diabetes or pre-diabetes. And what they have found is HbA1c may not always be correctly reflect actual blood glucose levels due to biological variations in red blood cell lifespan and glycation kinetics. So they have to rely on OGTT, and which is more sensitive in detecting pre-diabetes and diabetes, specifically in Indian subsets. Alternative glycemic markers, fructosamine, glycated albumin, and hydroglycitol assays are potential alternatives to HbA1c, especially in case of hematological abnormalities. And CGM and flash glucose monitoring provide real-time data as compared to the HbA1c that we rely on. So these are the recommendations. HbA1c should not be used as a standalone thing. OGTT remains the gold standard for diagnosis of prediabetes and diabetes. For monitoring, A1C should be complemented with fasting and postprandial always, and CGM FGM data can be helpful. Hematological assessment, including complete blood count, iron studies, and hemoglobin fluorescence for hemoglobin E disease, should be integrated into diabetes care, particularly in those places where we see anemia and hemoglobinopathies. With this, I conclude my presentation. Thank you.
Thank you, Dr. Rupam. We'll now have Dr. Manilka's perspective on that. You can stay on and we can have discussion.
Thank you very much, Rupam. I think I will compensate the extra 2 minutes. He did all what we discussed and covered the topic. So I'm between you and the gala dinner now. So let's finish in 2.5 minutes. I don't have any slides. Let's have few take-home messages for Southeast Asia in a resource-poor setting. Who are the patients who will really benefit by CGM, because which is a costly thing. India, it may be cheaper, but in our country, in Sri Lanka, it's a luxury to have a patch at the moment. It's very expensive. I would say a type 1 patient during pregnancy, and certain when you are, or a type 2 diabetic who is going on insulin, starting on insulin, or during a intercurrent illness where they are admitted to hospital or recovering from a major surgery. I would, recommend this thing. And what are the advantages? Price, cost permitting. I would say the variability, the Asian diet, especially in Sri Lanka, we have noticed in the people who take this thing, HbA1c of 7, he nicely showed that, could be, our understanding is, okay, his average sugars are 90 to 140, all are happy. But the CGMS shows that the sugars can be 50 to 300. Still, you get this thing. So then the patient gets the hypos and all the arrhythmias and the risk factors associated with that, sudden death associated in the elderly. And the hyperglycemia, which will cause the endothelial damage and increase their cardiovascular and the cardiorenal risk. So I think it's a very useful tool in people whom you suspect this variability. Clinically, we can get the signs of hyperglycemia and increase cardiovascular risk. You should do a profile and see whether that would be useful. So we can select our patients to use these new devices. I think it's a very useful tool even for us in this part of the world, especially with a high carb diet. The Sri Lankans, I can tell my experience, they have a very high carb meal at lunchtime. So if you don't measure the postprandial lunch, you don't get the correct picture of their glycemic control, which may be fasting is 80, postprandial is 350. So in those people, we can use it. Even in pre-diabetes prevention, in people who can afford, I have put a patch and they have corrected their lifestyle and got the HbA1c back down from the pre-diabetic level to a non-diabetic level. So this also is a useful tool in certain people. So I think, ladies and gentlemen, I'm sure you all are convinced that HbA1c, although it was the gold standard some time back, with the evolving technology, selected people, even in a resource-poor setting, I think CGMS would be a very useful thing for your practice. Select the patients who will most benefit so that you get value for money by investing in these new technological devices. So thank you very much and open for discussion. And we have a few more minutes before dinner.
Thank you. Thank you, both of you.